Good afternoon and good evening, dear friends and colleagues. I'm very pleased to welcome you to the third special online seminar on megaprosthesis infection. We prepared today very interesting topics, and as promised, it will get more and more complex. So today the title is Tips, Tricks, Facts and Myths. And I'm very happy that we have again our faculty as last time from different countries. From Germany, Professor Volker Alt; from France, Dr. Fabrice Fiorenza; from UK, Professor Lee Jace; and myself from Charité Hospital in Berlin. We will first speak about rational background on treatment decisions, and then continue with general treatment concepts, followed by individualized treatment concepts, and then really go to the shitty cases when everything fails, which salvage procedures can be considered. Then we have three cases which we would like to discuss with you. So please feel free to comment, to ask questions in the chat, and we will discuss it with you. Also, you can put your EFN number in the chat so that on the certificate you can claim your CME points. For Germany, it's automatically then you can put it in. For other countries, you need to see with your medical chamber, but it should be recognized. Your questions will be discussed during two opportunities today, and you can find also later on in the download area literature, which we prepared for you. And of course, also you can access the pocket guides, which can be downloaded from the website of the PRO-IMPLANT Foundation. So with this, without further ado, I would like to start the first presentation with a background for treatment decisions. We talked about this already in the last presentations, but let me summarize a couple of points which may be important for the later discussion. First, there is a very good paper related to fracture-related infections, published 2018. It's a consensus on definition from an international expert group. The second interesting paper is about pathogenesis and management of fracture-related infection. Both are not directly or specifically to megaprosthesis, but many principles apply to it, including the diagnostic workup, which should be the first step in a good treatment plan. Let's go through some preoperative and intraoperative diagnostic procedures. Which are the criteria which tells us that there is an infection? Of course, in acute infections, it's already clinical features. We will see today cases with a sinus tract or visible purulence. But if we can come to the implant, and this test is called probe to implant, and we can hear the sound of the metal, then it's already enough to call it infection. Histology is useful for the chronic infections and those who are of low grade. Then we have some radiological points and, of course, microbiology to know what is our enemy. The most common enemies are here listed. We see that staphylococci, including resistant bacteria, staphylococci are the most common pathogens, but the more complex the situation is, the worse the soft tissue, and the more often the patient is operated, the more the microbiology switches to the gram-negative bacilli. We can see here listed some of them, and Pseudomonas aeruginosa is probably the most resistant one, but often we have also mixed infections, including anaerobes and fungi. polymicrobial infections occur especially in those cases where we have bad soft tissue and the previous VAC use, or better to say misuse. So in this article which I mentioned before, the consensus of the international expert group, there is a nice algorithm which shows that we always start with a clinical evaluation, lab and X-ray, and then we follow with some confirmatory criteria listed here: implant on view, or so-called probe to implant test, sinus tract and purulent discharge. Then with imaging, we can see the bone situation, with MRI also the soft tissue situation. And then we go into intraoperative diagnostic tests, where I would like to mention some specific topics. First, that we should take no swabs, but deep tissue cultures. The best is of the tissue which doesn't look nice. And then we cultivate them for longer than 1 week. The best is for 2 weeks, so that also the low virulent bacteria will grow. If we remove any of the implant, and that can be also spacer if there is a present, then we can send it for sonication, a procedure designed to remove the bacteria which are on the surface of the implant or the spacer, with 1 minute of sonication, so ultrasound of 40 kilohertz, we can remove the bacteria and detect them in the fluid, which is then called sonication fluid. It's a very easy procedure, and sonicator bath is enough to detect these bacteria, which are then cultivated on the plate and increases the sensitivity to about 90%. The other rational background of decision is that probably the most important factor influencing the outcome is the surgical debridement. Only if this is done properly, then the local and systemic antibiotics can achieve success. So when combined both the proper surgery and proper antibiotics, there is a high success rate. And this is schematically shown here, that with sufficient debridement, we reduce mechanically the number of bacteria to the level where systemic antibiotics can do the rest, especially if we can combine it with local antibiotics, implant coating, and potentially new methods such as phage therapy. Antibiotics alone has success below 10%, and with a not proper selection of patients, we will also have bad success. So the question is, in the case where we retain the implant, is it possible to eradicate the infection? If not, we still have the possibility of suppression, and we will speak about this today later. But when we speak about eradication, then it's important that we retain the implant in early infections, where we have a young biofilm, whereas in chronic infections, we need to exchange it in 1 or 2 stages. Otherwise, we go for suppression, which can be for 1 year, 2 years, or lifelong. But the most important, especially in open fracture, is the quick empiric antibiotic treatment. The best would be within a couple of hours, but at least the same day, with a broad spectrum antibiotic, which can be either piperacillin tazobactam in most European countries. That is enough. In countries where there is a more multi-resistant prevalence, then we need to go 1 step higher, and this is the combination of meropenem and vancomycin, until we know more what is the pathogen. And when we know more, then we switch to the targeted treatment. And after we do the surgical procedure, we switch to biofilm active antibiotics, which in most cases, fortunately, can be given orally. So the key point to biofilm eradication strategy is that we switch to oral antibiotics when the soft tissues are okay and the wound is dry. We know the pathogen, and then we switch to one of the biofilm active antibiotics based on the table, which is part of the pocket guide. And I will not now go into more details because you can see it in the pocket guide. But as a general rule, we start IV, high dose and broad. Then we oralize when the wound is dry and the systemic parameters are reduced or even normal. When we cannot eradicate the infection, this is, for example, when we cannot remove or exchange the implant, or we have a resistant pathogen, we look if we have one of the antibiotics available, which can be used for long-term suppression. So we do not eradicate the infection, but we suppress the symptoms. And if the patient is happy, there is no pain and good function, we have several cases with a good suppression. At this point, I will tell one secret, which we have not published, neither explained on conferences. And there is a trick. If you have a megaprosthesis, where you know that the infection is still there, but you want to suppress it, instead of giving one antibiotic over years, we can do the so-called cycling. Cycling means that we give one suppressive antibiotics for 3 weeks, and then before resistance occur or toxicity, we switch to another 1 or 2 antibiotics given for another 3 weeks. And then before resistance occurs, we switch to the 3rd cycle. And then the 4th cycle is antibiotic free. And then we restart again with the 1st, 2nd, 3rd cycle. And with this so-called cycling approach, we could suppress very efficient infections on the long term with very little side effects. And because we confuse the bacteria with always new antibiotics, there is also no time to get resistance. With this, I over through the first presentation, and I'm happy now that we start with the second one. I think it's Volker Alt, where we're speaking about the general treatment concepts, especially the very useful classification TNM, which guides also for the treatment. Volker, please.
Thank you very much, Andre, for the introduction. Yes, today we want to talk about treatment concepts. We all have to make decisions about the treatment that we recommend to patients, and therefore we need some guidance. And I had the opportunity to introduce to you this new TNM classification the last time. I just want to remind you that particularly in the context of people that are doing megaprosthesis, this TNM PGI classification, this is not an oncology classification, but it's a PGI classification. So it's a classification for periprosthetic joint infections, which is based on oncology aspects. I just want to remind you that we have those 3 criteria, which is the T, the N, and the M. T stands for the local tissue and implant conditions. N is for the microorganisms, for the non-human cells, which can be bacteria and fungi. And M, and I find this very important, and we will discuss that, is the morbidity of the patient, because particularly also in megaprosthesis, we sometimes have to deal with patients with high comorbidities. So each classification should aim to guide treatment decisions. And particularly for PGI studies, we know that the literature is based on many studies that do contain a very broad range of patients, and the patient setting is quite heterogeneous. And we believe with a better classification, we can also improve the quality of our clinical studies in order to have more reliable and more compact to guide treatment decisions. If we look at the first, at the T, you see that for tissue and implant conditions, we have to consider whether the implant is stable, whether it's loosened, or even if we have a severe soft tissue defect. And the T0 is for a stable implant, the T1 is for a loosened implant, and the T2 is a situation where you have a severe soft tissue defect. And here, additionally, we have included the letter A for standard implant and B for revision implant in order to show and to respect that aspect that revision implants are more difficult to treat compared to a standard implant. As you can see here, in this context, we can also, and I'm really thinking about that, whether to include also a C in that context, which would include the megaprosthesis. So we would not have only A, B, but also C, which would make that classification also very useful for megaprosthesis infections. So what can the T give us as a guidance for our treatment? I think it's pretty straightforward here, because if you have a loosened implant or a situation with a severe soft tissue defect, so you should definitely exchange your implant. So it's a one or even a two-stage or a multiple-stage procedure. And the T2 with a severe soft tissue defect should guide you to your colleagues from plastic surgery to think about an additional flap surgery. And also for the T0, we can have some guidance, because we know that if you have a stable implant in an acute situation, the implant can be retained, and in the chronic infection, even if you have a stable implant, this should be removed. Whether it's acute or chronic, this is then be guided by the next letter, which is the N. The N, we found we had to respect the T and M abbreviations, and for N we chose the terminology non-human cells, which stands for the microorganisms, for bacteria and fungi. And also here we can get some guidance from this N, because we classify as an N0 situation all situations with an immature biofilm, so with an acute infection, which can be either in the N0A situation directly postoperatively within the first 2, 3, 4, 5 weeks after surgery, or it can be the late heterogeneous infection after 2, 3, or 4 years, starting off with a very acute symptomatic in a joint that has been painful, that has been pain-free, and the patient got along with that joint quite a long time without having any problems. This would then be the situation N0B. For the N1 and the N2, we do have a mature biofilm, which means this is a chronic infection. And here we differentiate between the N1A, which is without difficult to treat bacteria, so the easiest situation. The N1B is a mature biofilm with a culture negative infection, and then N2, A, B, and C, then it's getting really difficult, because the N2A, you have a difficult to treat bacteria, which would mean a rifampicin resistant, Staph aureus, for example, or a ciprofloxacin resistant gram-negative organism, or in the N2B, you have a polymicrobial infection, and then this, for many of us, and also for me, a very difficult situation if you have a fungi infection, which then would be classified to an N2C. And so also here we can have a good guidance of our treatment, because in the N0 situation, where we have an immature biofilm, we can do implant retaining therapeutic concept. In most cases, this will be a debridement, antibiotics, and irrigation, the so-called DARE. And in all other situations, in the N1 and in the N2, we would have a chronic situation in which implants should be removed. The M is standing for the morbidity of the patient, and I also announced that I think this is a very difficult and important part to consider, because we know that for oncology you treat young patients, but also for the megaprosthesis after trauma or several revisions, it can also be geriatric patients. And here you definitely have to look at your patient. How sick is the patient? What comorbidities does the patient have? And this has to be considered, particularly also regarding his anesthesia risks. And here we have classified the M0 patient, or we use for this M classification, we use the Charlson Comorbidity Index, which you can see here in that little table. This gives scores for the underlying chronic diseases of the patient, starting from myocardial infarction, dementia, and so on. And for each morbidity, you get a separate score, let it be 1, 2, or 3, and then you add up this score, and then this shows you whether your patient is not or only mildly compromised with a Charlson Comorbidity Index of 0 or 1, moderately compromised with a Charlson Comorbidity between 2 and 3, severely compromised with a Charlson Comorbidity between 4 and 5, or even higher than that. And then you end up with a patient with so-called M3 patient. And this is now very well established in our department. When we talk about M3 patient, this means that the patient cannot or should not be operated on, because either the patient is just too sick that he would not survive a big surgical treatment, multiple exchange procedure, or the patient refuses surgical treatment. I think we all aware that sometimes we have patients and we recommend a treatment and the patient just says, no, I don't want to be operated on. This also has to be respected, and this patient is considered in our classification as an M3A patient. And the M3B situation is that the patient does not benefit from the surgical treatment. So particularly if you have a chronic total knee infection with the loss of the extensor apparatus, and you are not even able to restore that, so a new knee prosthesis would make no sense in such a patient. So he would not benefit from a functional outcome of such a big procedure. And so here also the guidance, I think, is pretty straightforward for this M3 patients. As I said before, they cannot or should not be operated on. And on the other side, if you have M0 or M1 patients, which are systemically healthy, they don't have high anesthesia risks. So you can discuss the big surgical options with those patients. Whereas in the M2 situation, where you have a severely compromised patient, these are critically ill patients. They are no good candidates for big surgery. And taking that all together, I think this TNM classification that I just presented can help to give you some guidance for a general treatment concept and for a general treatment recommendation for your patient. And I have listed now 2 examples that I would like to share with you. This first case is a chronic hip PGI in a severely compromised patient. The patient is 86-year-old. He had several cardiac infarctions. He was resuscitated 2 weeks ago. He is on dialysis. He is diabetic, and overall he has a Charlson Comorbidity Index of 7, which means that he's a severely compromised patient. This patient had a proximal femur replacement 2 years ago after an aseptic revision arthroplasty. It's a revision implant, but he doesn't have any soft tissue defect, but he does have, after joint aspiration, he does have a polymicrobial infection with Staph epi and Enterobacter cloacae. So if you take that together in that TNM classification, you come to a T0B, which is you have a stable revision implant without a soft tissue defect. You have a difficult microbiological condition with a polymicrobial chronic infection, which is an N2B, and you have a really severely compromised patient who would not survive a 2-stage big revision surgery. So this is M3C situation. So if you take that together, T0B, N2B, and N3C, this in this case would mean that surgical treatment is not recommended, and we put him under a suppressive antibiotic treatment, and the patient died after 4 weeks of this antibiotic therapy. So he was really at the end of his life when presenting with that severe situation. And he would not have benefited from any surgical treatment. On the other side, this is another case with an acute postoperative periprosthetic knee joint infection. You have the 77-year-old female who does have some chronic heart or congestive heart failure. She has a mild COPD with a Charlson index of 2. She had a total knee arthroplasty 2 weeks ago, so pretty early. She had no loosening and no soft tissue problem. And the puncture showed the detection of a Staph aureus with a susceptibility against rifampicin. So this is a completely different situation to the first situation, because if you classify that, you find that this is a stable implant, not loosened, implanted just 2 weeks ago. So it's a T0A. But here, because it's only 2 weeks, we have an immature biofilm. And this is acutely post-operative, so it's only 2 weeks after surgery. So this is the N0A situation. And the patient is only mildly compromised, so it's an M1. So if you take that together, you have to deal with acute postoperative infection with easy to treat bacteria, because you have a rifampicin susceptible Staph aureus in a only moderately compromised patient. So in this condition, a DAIR is indicated because you can retain the implant, you can operate on the patient, you have an immature biofilm, and with a smart use of your antibiotics, with particularly the use of rifampicin, once the wounds are clear, you can definitely have a good chance to retain the implant. We also believe that we cannot only give treatment decisions and cannot help with scientific studies with that classification, because we think that we can also tell something about the prognosis. This is also what the TNM classification in oncology does. Because if you look at the way we chose the classification, we start on a very simple level and then go down and make it difficult. The more we go down in each letter with the T, we start with the T0 with a stable implant without an important soft tissue defect, and then we end up with a T2 with a severe soft tissue defect, which makes the situation much more complex. Also, for the bacteria, we start with the easiest situation, which is the immature biofilm situation directly postoperatively, and we then end up with the letter N with a complex situation, chronic infection with fungi. Also for the comorbidities, we start with the easiest situation with a healthy patient and end up with a patient who would not survive surgical treatment. So please let me summarize. This classification system can give some guidance for your treatment decisions for your patients. And we also believe that it can help to predict outcome. We know that we have to validate that, and we are already doing that. And I hope that for one of the next webinars, I can present more details on that scientific validation. But I can tell you, for the first analysis that we have done with our patients, it looks quite beneficial, and for us it's really a good tool to guide our treatment for PGI patients. Thank you very much for your attention.
Thank you, Volker, also for this very useful and structured category. We will continue now with from a general concept to individualized treatment concepts with the patient-adapted strategies, which will be presented by Fabrice Fiorenza. Fabrice, please.
Thank you, Andre. Treatment modalities of a prosthetic joint infection is now well documented, and you all know this beautiful algorithm published by André and his team at La Charité. And in order to help us choose between these operation, between these management protocol, Lee, in the last webinar, showed us how to rationalize our choice decision using mainly 4 criteria, which are the type of infection, whether it's acute or chronic, the soft tissue quality, the type of organism, and of course, whether our patient is a good host or a bad host. But before embarking on a treatment plan, the treatment team, the physician must ask key questions. First of all, we must know our patient, and we must assess the risk factors, because we know that these risk factors are going to compromise the outcome of treatment of a prosthetic joint infection. And Macpherson in 1999 published this classification based on the infection type, the systemic host grade, and the local extremity grade. And so basically, at the end of the day, if your patient is a type 1A1 patient, we know that there on the single stage revision surgery will give probably a good result and a good success rate. On the other end, grade B or grade C host will be more likely to have a failure as a result. So we have to be very careful. Of course, I strongly advise to use the TNM classification that Volker has just presented us. And another important point is to remember that a quarter of patients treated for PGI are dead within 5 years. And this is very important to remember. These patients have got worse prognosis than some cancer patients, like prostate cancer, melanoma, or breast cancer. So this is something we need to remember before embarking on a 2-stage procedure. If your patient has got 2 years to live, you don't want to keep him in hospital for 3 or 4 months. So we really have to think about this. The quality of soft tissue, we need to assess this in order to know if we need a plastic surgeon. And of course, it would be different to do a free flap, 25-year-old with a megaprosthesis compared to an 85-year-old, of course. The specificity of surgery, we must know what we need, how much bone we need to resect. Do we need some modular system? Are we going to use silver? Are we going to use some special designs? And if you plan to a special design and the collaboration with the engineer, maybe this collaboration will delay your treatment plan. So you have to think about this. Next question is my patient fit for a 2-stage surgery? That's Volker has spoken of this just now. McMull in his study showed that the success rate of the 2-stage procedure was only 63%. And in this other study, Tigani showed that for patients with 2 major risk factors, the cure rate was only 67%. So this is very important to think about this before choosing this treatment protocol. This article was published a few years ago by Jay Parvizi and his team, and they investigated the clinical course of spaces for 2-stage revision surgery. And so they had more than 500 PGI, and the reimplantation rate was only 82%. The success for the patients reimplanted was 80%. And the mean duration between T1 and T2 was 4 months, which is quite a long period of time for patients who have a compromised prognosis. 17% had no reimplantation, and 7% of the patients died in the interstage period. which is very important to consider. And in the published studies, two-stage revision surgery, most of the time the cure rate published are the cure rate after the second stage. So they don't include the patient who died. They don't include the patient who who had no second stage. So this is important to consider. And of course, you have to ask your patient what they want. You have to discuss with the patient, of course. You have to discuss with the family, and maybe the patient don't want any operation, like Volker just pointed out. And chronic fistulization or suppression antibiotics is maybe a good option. So this is a 65-year-old man who had a chondrosarcoma 20 years ago. He had a resection and a reconstruction with an APC technique. And 7 operations later, he shows up to my clinic in severe pain, and there is a loosening of the inverse prosthesis. He has a very limited range of motion, and he clearly needs revision surgery. I'm a bit concerned because you can see on the X-rays more metal and more cement than bone. And the skin at the anterior aspect of his shoulder is very thin, and I don't trust this. So I did an aspiration, which was negative, and then I had very little bone left. So we thought about this paper published a few years ago by our friends working in London, showing that you could have a good fixation with the extracortical plates. And so the engineer designed this nice custom-made implant with extracortical plates for this very distal fixation. I planned a pectoralis flap. I didn't want to touch the glenoid because there was I didn't know what bone I had to find if I revised it. So I wanted to keep the glenoid implant. And so they designed this nice prosthesis. These are the X-rays. So I was happy for just 3 days, because 3 days post-op I did systematic positive samples, and they came back positive with MS Staphylococcus epidermidis. So what to do? I had kept the glenoid, so that was a bit worrying. We discussed the case in the MDT, and we considered that there was small risk because I had done a good debridement during the operation. I used a silver-coated implant, and the WAFA paper showed us the risk of infection with silver-coated implants in case of positive cultures was quite low, 13% compared to 40% for non-silver implants. I had given cefazolin just after the operation, and so we could switch to proper antibiotics with rifampicin and levofloxacin. And it went well. So 3 years, he had no pain, no fever, and skin and flap are perfect. So I think we did the right choice, but it was quite a discussion at that time. In this patient, 64-year-old woman, she had a periosteal osteosarcoma in 2011 of her left mid-femur. She had no mets, so I did a diaphyseal EPR. She did well in the beginning, and she developed lung mets, 2 lung mets a few years later, which were treated with radiofrequency ablation and some chemotherapy. And then she complained of pain in the proximal femur. The local staging didn't show any local recurrence. The CRP was 9 milligrams per liter. Did a bone scan. There was a bit of fixation. I did an aspiration. And of course, there were these 3 germs. So 70-year-old lady, 2 lung mets treated with RFI the year before. Should we do a 1-stage, 2-stage? With 2 lung mets, I didn't want to put her in bed for a long time. Should we do a diaphyseal EPR, to revise the diaphyseal EPR with a new diaphyseal EPR? That means I would probably need a 2-stage revision surgery. Should we do a proximal femur? but what about the distal femur, or should we do a total femur? So we discussed this with her, and she was otherwise quite fit for a 70-year-old with two lung mets. But she was okay for a one-stage revision surgery with a total femur. I used a silver-coated total femur, and we gave her 3 months of antibiotics. And now she's at 3 years follow-up, and she's still alive. She's doing fine. She has no pain, with a Hennecking score of around 25. So I think that was a good choice for her. We were lucky, no complications, but that was worth doing. So this patient is a 70-year-old man with diabetes, and he had a pathological fracture of his right femur below a total hip replacement. We did the staging, biopsy, and it came up with a spindle cell sarcoma of bone with no metastatic disease, so he had a bit of chemotherapy. And then came the surgical plan. So I didn't want to touch the hip because the hip was very stable, wasn't painful at all. So we thought about keeping the prosthesis, and there is this nice paper published by the Birmingham team. It was at that time Lee wasn't even in the team, I think, in 2006, and we designed this custom-made implant cemented around the distal tip of the hip prosthesis, and then you could connect the distal femur. So we did this. He was happy, but 6 years later, he came back with an acute infection, with pain, fever. The leg was swollen, red. Aspiration gave Streptococcus galloluticus. So we did the cardiac scans, which showed no endocarditis. And the coloscopy, we found the one polyp, which was probably why he developed this infection with Streptococcus galloluticus. Acute infection, so I did a DARE with, I changed the silver-coated parts and all the distal femur, basically. And we gave amoxicillin for 12 weeks, but it didn't work. A few weeks later, a few months later, he had still a bit of fever, a bit of pain, CRP was a bit high. So I did a new biopsy in theater just to make sure that there was no other germs, and Streptococcus galloluticus came back again. So we discussed what should we do. Why not do a silver-coated total femur, one-stage surgery, but 84-year-old patient, so a bit old for this. And in fact, the fever was very mild. It was not that painful, and we discussed with the patient, with his wife, and they refused the new operation. As Falk pointed out, he was an M3A patient. So we gave suppressive antibiotics, and 5 years later, he's still fine with the antibiotic suppression that works perfectly well. So I think we were right to listen to our patient and to refuse not to do the operation. So in conclusion, treatment of PGI infections is easy when you look at this nice protocol, this nice algorithm. But in fact, we should remember that each patient is unique, and we should tailor the treatment depending on these criteria. We should always assess the risk factors, use McPherson classification, and of course the TNM1. We should always remember that the prognosis is bad. 25 of these patients will be dead within 5 years, so we have to keep that in mind. Soft tissue, that's important. We need to assess if we need a plastic surgeon. Special design, think about that. And always ask yourself if your patient is fit for a 2-stage revision surgery. There is 7 to 8% mortality in the interstage interval, so beware of this. And of course, we should always listen to our patient and listen to what they feel like. If they want no operation, no operation. If we can give a nice cyclic antibiotic suppression, let's do it. Thank you.
Fabrice, thank you very much, especially that you presented so many modern approaches from silver coating, suppressive antibiotics, cycling, local antibiotics, and also still a structured way in a type of algorithm. And this is a perfect now introduction for the next talk from Professor Lee Jace, when everything fails. And I'm very curious now to see what Lee, thank you.
Okay, so I'm going to talk about the end game when nothing else has worked. I think most people know me, but for people who don't, I'm in orthopedic surgeon in Birmingham. We're pretty academic, and we specialise in tumours and infection. So Morgan Freeman said, if you're not living on the edge, then you're taking up a little bit too much space. And we all enjoy challenges in life, and the balance between work and more enjoyable things is something that we're all trying to get the balance from. But sometimes things don't go as well as we'd hoped they were going to go. So my practice is very unusual. We're a national referral practice for mainly tumours, but also we became well known for doing failed revision total hip replacement. So 60% of my orthopedic practice, non-tumour practice, is infection, and 90% of it is re-revision. So I don't get the chance to do nice straightforward primaries or first time revisions very often. And so we specialised in horrendoplasties, and if you look on the internet, then it is a thing. It's a difficult and time consuming operation, or in the Americans call it god-awful surgery with a probably poor outcome, which sometimes surgery can be. But they all have common themes. So they often have infection and bone loss and poor soft tissues. They are often poor hosts. They've normally had multiple previous surgeries, and this is often their last chance at surgery. And if you're going to do these very difficult cases, then you need to be able to deal with a multitude of problems: bone loss, soft tissue, infection, and fractures. And so you have to be able to have the sort of guts to do them. The most important thing I find when we get these complex cases is that we have to set the expectations. And so for orthopedic patients, when they've come with multiple revisions, then I start off by telling them how serious it is and always offer them an amputation first. And normally they say, well, that's why we've come to you, because we heard that you don't want to do amputations. But it makes the patient realise the severity of the situation, and that this is limb salvage. Even if it's not a tumour, we are trying to save your leg. So we say, okay, well, if you don't want to have an amputation, we'll try this, but we might still end up with an amputation. And it's important that we keep to first principles, so that we treat the infection and the soft tissues first. And there's no point going ahead with any reconstruction until the infection is eradicated. So you almost have to be slightly schizophrenic and then deal with radical debridement and the soft tissues, and then go, oh my God, how am I going to put this together again afterwards? And it's very important that we have a multidisciplinary team approach. So we have the ability, because of tumour surgery, to do our own flaps, but we also have plastic support. We also have a tissue viability team, and we have the infection team, which involves outreach, IV antibiotics, and a multidisciplinary team meeting every week. And it's important that you're radical and you resect as much of the dead tissue as possible. You have to resect everywhere that is infected, both bone and soft tissue, and take it slowly. There's no urgency to try to get into the second or third stage procedure. It's really important that we keep on going until we think we've eradicated the infection. And don't think that you'll be lucky, and don't hope that it's all going to be okay. But there is very little that you can't reconstruct. And you always have to remember that you can make things worse as well as better, because there's always something that comes along to make things worse. These are my average increase in Oxford hip scores for hips and knee revisions, and you can see that we're do pretty well above national average. But the reason why I present the change in Oxford hip and knee scores is because most of my patients are bedbound when we start off, and we hope to be able to get them walking, perhaps with have a stool when you can't even get out of bed. These are our results by operation type. So you can see that we have about a 10% failure rate for DARES first stage and 2 stages, but we have a 50% failure rate if it's a combined bacterial and fungal infection. This paper, a very small series, looked at the outcomes of re-revision knee replacements. 8% of cases didn't even survive 30 days. 20% of cases didn't survive a year, and a quarter of patients didn't survive for 2 years. And you all have that feeling of, well, I really wish that I'd not operated on this patient, because you know that they're going to follow you around. And there's a German surgeon friend of mine who says that if you operate on them, that you marry them, and therefore you're going to end up with the patients following you around from clinic to clinic. And then it becomes a blame game. The patient blames you, you blame the patient. And so when I see a patient with this, an obese patient with an open wound on the knee, I'm thinking, oh my God, this lady could end up as an amputation. But the lady herself is thinking that she's going to be dancing again for the Bolshoi Ballet. So the question we've really got to consider is, can we or should we consider limb salvage in some of these very, very severe cases? This is a very busy slide, but I'll take you through it, and I'm sorry it's appeared like this. We've just, this is about to be published in the journal Knee. We looked at 32 patients that underwent a re-revision for infection, having failed a previous 2-stage revision at another unit, and we compared those to the cases where we had done the 2 stages. So if we look at the headline figure, we were only able to eradicate the infection on 50% of the re-revision infections at the first treatment episode, compared to 91% in those that we'd done a 2-stage ourselves. Most of the patients, well, 44% of the patients had needed a reoperation, compared to only 9% in our group. However, we only performed amputation in 1 case, or 3%. And the infection was actually able to be controlled in the other 13 patients that had failed our first operation by either DARES, further revision surgery, or going on to an orthodesis. And we had a 6% mortality rate. And therefore, our long-term control rate for infection was 91%. So what the point of this study is that clearly it is difficult, and you often have to go into multiple stages. So you can't think that a 2-stage revision for these patients is going to be enough. It may well be a 3 or even 4-stage revision. And this was the algorithm of the patients who'd passed, which I can share with you later. We do our own gastrocnemius flaps as orthopedic surgeons. We had a 100% flap survival rate. And using limb salvage as their outcome, we were able to maintain the limb in 3/4 of patients. In these patients, all presented with over 10 centimetre defects. So what factors cause me concern? Well, you've heard from Volker and from Fabrice that poor host, poor soft tissues, multi-drug resistant organisms, which we haven't talked a lot about, but we published a paper on their outcomes, and interprosthetic fractures all cause me to worry. In the hip, major bone loss down to diaphysis is a concern, and in the knee, extensor loss mechanism remains a concern. And these are the cases that are becoming much more frequent in my practice. Interprosthetic fractures, so a fracture between a hip replacement and a knee replacement, often both long stems, often in very poor patients who the trauma surgeons have already tried to fix. So what are our options then when everything else has failed? We've got a failed 2-stage revision. Well, I've told you that we can carry on going, and I would recommend considering referring the patients to a specialist centre that specialises in re-revision or complex cases. But the other things that we can think about are antibiotic suppression, as we've talked about, long-term antibiotic spacers, girdle stones or amputations, or very rarely rotation plasties, knee arthrodeses, and then total femurs or push-pull. Antibiotic suppression. Antibiotic suppression is suitable for the elderly or the highly comorbid patients we've heard about, where surgery is unacceptable to the patient and they have a low output fistula. This is often managed with a chronic fistulization with a colostomy bag on the wound. But it's important that we know the oral antibiotic sensitivity profile for these patients. It's very difficult to suppress patients which have multi-drug resistant organisms. We've heard from Andre already a protocol that we use as well, where we will cycle antibiotics, so 3 antibiotics alternating in our case every 4 weeks with a month off. So we can, sorry. Trying to look at the literature, there's very little in the literature about suppression, but this paper had 26 patients with a high comorbidity index. They looked at whether the patients returned with sepsis or required an amputation, and they found that in 20 of their patients who'd had a 6-week course of antibiotics prior to surgery, they were able to manage with suppression. They only had 2 patients that required an amputation for persistent symptoms and 2 patients who had admissions to hospital with sepsis, and therefore the success rate at 3 years was about 85%. So it is a viable option. Andre's group published a paper about the long-term suppression of streptococcal infections, and interestingly, in streptococcal infections, they found that prolonged antibiotics with a streptococcal infection helped to improve their outcome of 93% versus 57%. What are the problems with suppression? Well, I've already alluded to the fact that multi-drug resistant organisms don't do very well with them. High output fistulas are difficult for the patients to manage, and if you have a retained metal, you have to expect that you're going to get progressive ongoing loosening, which may lead to further symptoms. You're going to have an ongoing biofilm, and you may develop bacterial resistance. One of the strategies that we are very keen to employ is that we tend to leave patients who are not suitable for major surgery with very long-term antibiotic spacers. The advantages are there's no metal at the surface. You can add antibiotics in high concentrations to your cement, and it maintains the function of the limb. So if you've replaced the hip, the knee and ankle are still working. If you've replaced the knee with a spacer, you've still got a hip joint and knee joint. And for us, this is a better option than amputations. Disadvantages are they can often not fully weight bear, and they will often fracture eventually, normally after about 2 to 3 years, in which case we tend to either change them to a definitive prosthesis if the patient's still alive, or think about another spacer. This is this patient who's had a spacer in for 3 years and represented with a fracture, but during that time they had continued to mobilize. This is a tumor case of a pelvic reconstruction, and you can see that though the spacer has fractured, you can see that 10 years later the patient is still mobilizing with crutches on that spacer. In the hip, the girdle stones excision arthroplasty is often used. It's got high rates of getting rid of the infection a 92% success rate, but on average, the patient has 4 centimeters of shortening, and only 3/4 of patients are happy. And I don't really know if there's any advantage over this than continuing with a spacer and not proceeding to a second stage. It's not easy with an EPR, but as you can see, we make custom-made long-term spacers, and actually ImplantCast, if you send them X-rays, will make you a custom-made spacer for the size you need. And the outcomes, this study looked at 63 patients. This study with actually looked at 63 patients, and the quality of life scores for patients who had a girdle stone was lower than that of an amputation, or in fact lower than that of patients who'd had heart attacks. 30% of patients in the lower study were chair-bound, and 60% needed Zimmer frame. That means only 10% of patients with the girdle stones are mobile with simple walking aids. Amputations, we desperately try to avoid amputations. Most elderly patients won't use a prosthesis. You need very strong upper body strength to consider training, even if you do get a leg. Phantom limb pain is more likely in painful conditions, so consider a preoperative epidural. And it uses approximately 150% VO2 of your oxygen requirements to mobilize with an above knee amputation, and 160% if you have a hip disarticulation. This is a young patient who's had a hip disarticulation or hindquarter, and the young patients can cope very well with them. This young lad is one of the best amputee footballers in the UK, but that is for a young and fit patient. Okay, if we can move on, please. Rotationplasty is described. Winkelmann described 12 cases for failed EPRs. 9 out of the 12 were successful, but 3 went on to have amputations, mainly because of vascular problems. Their functional score was better than the amputees, so there's no doubt that it does give you better function, and their quality of life scores was significantly better than the amputees as well. It's not a situation that we employ very often, but this patient had a rotationplasty for a tumor. And you can see here, as the patient wakes up from the operation, you can see them starting to move their toes. And then we'll ask them to undergo brain training afterwards. You can move on, please. And the reason why we do this operation is to convert a hip disarticulation into effectively a below knee amputation. And here you can see the patient wearing effectively a below knee prosthesis. You can move on. And when we see the patient walking with trousers on, we can see that rather than walking with crutches like the first footballer we saw, they can remain independently mobile with a relatively normal gait. It can be done at the hip. This was a revision for a failed diaphyseal reconstruction, and you can see that we can either put the distal femur against the pelvis, or in the unusual case on the left, we've actually put a hip replacement into the knee. Knee arthrodesis is my standard approach, particularly in the knee. If we don't think we can get a mobile spacer in, it's very good if the soft tissues are poor and you don't require an extensor mechanism. In the first stage, we'll use a static spacer and leave it for as long as possible, on average about 6 months. This means the patient gets used to having a straight leg, and it allows the soft tissues to settle as there's no flexion. If there's only a small amount of bone loss, you can use this type of arthrodesis where you can achieve bony union. But if we have a larger bone loss, then we'll need to consider a diaphyseal replacement with it. So this was a failed proximal tibia replacement. The patient was unfit, so we did a 1-stage revision for this patient, removing the implants and doing a thorough debridement and a gastrocnemius flap. This is the same lady just 10 days after the operation. Everything has healed up nicely, and you can see that we've reconstructed it. Interprosthetic fractures are becoming more common, and the last things that we will think about are a total femoral replacement. It's important to remember that 50% of infected total femoral replacement ends up with a hip disarticulation or suppression, and so it's no mean feat to revise an infected total femur. For the intermedullary cases where there is intermedullary total femur, have worked quite well in our hands. So here you can see you have a combined hip replacement and knee replacement with a long intermedullary rod, on the left for infection and on the right for fibrous dysplasia. And so here we have a case of a very severe rheumatoid lady. You can do a total femoral spacer, but they often dislocate. But we were able to eradicate her infection with a total femoral replacement. So I think it's very important that we tread the line carefully. We must cross the lines that need to be crossed, but we must not overstep the mark. I think we have to be very careful of being very cautious. This was a terrible case of a infected long stem knee replacement, which would have been relatively straightforward for us to revise, but the local surgeon went straight for an amputation, leaving an unstable knee on the other side, which we then had to revise. I think there's very little that can't be salvaged, but we always wait for a patient to ask for an amputation, but we always offer an amputation. Amputations don't do very well in the over 50s. I think knee arthrodesis is an excellent option. And if you don't feel confident in dealing with these difficult cases, make sure you think about referring it to a unit where they're very used to dealing with these difficult cases and specialise in limb salvage. And we tend to use a lot of long-term spacers. Thank you very much.
Lee, thank you for these extraordinary cases. I knew that you will really show the most difficult situations, and showing that there is always a possibility to salvage. And only if the patient asks for amputation, then you go for that direction. I think we have a lot of points we can discuss. Maybe we continue now with the cases, and then we have probably a lot of topics we can discuss. So here it would be good if we start with the upper limb megaprosthesis, which will be presented by Volker. And this is for the first time that we speak about upper. We always now focus on lower and the pelvic. So I hope that Volker, you can join us at this point.
Sure.
Excellent.
Sure, yes, we have mainly discussed lower limb cases. Therefore, we decided to go for one case of the upper extremity, and I want to present one elbow case, one trauma case. This is a 62-year-old male patient who sustained a polytrauma injury with a grade 3A open elbow with this complex articular fracture with a dislocation of the elbow, and you see this complex distal humerus, and particularly also this complex proximal ulnar fracture. And this was the soft tissue conditions that were at that stage resolved by this distal lateral upper arm flap in order just to get the soft tissues closed. But as you can imagine, this is an important point to consider for the further surgeries. This was then the situation after resection of the distal humerus, because this could not be safe. There was no way for fixation of that situation, and also the proximal ulna at that part was resected at to a certain extent. We still believe that the bone could be of help for the elbow prosthesis. So then the wounds healed well. The patient had that external fixation for like 6 months in order the elbow prosthesis was then taken into account. The major problem here in this case was the major bone loss at the ulna, and therefore a custom-made implant had to be produced for that case, which was done in this fashion. You see here the replacement of the proximal ulna and this long stem that could then be introduced into the ulnar shaft. And this was then the situation 6 months after the trauma, the implantation of the elbow prosthesis. You see that the X-ray shows the correct implantation of the prosthesis with a cemented anchorage in the distal humerus and also in the ulna. And this was the situation the patient had for like several months, and he got quite good along with that. He was satisfied. This was 15 months after surgery, and he then also achieved a nice range of motion, as you can see here, and he was very happy with the situation. But 18 months after surgery, he comes back with pain in his elbow, pain in his forearm. You see here that the stem in the ulnar component broke. So this was the explanation of his pain. But for me, the question was, because it was an underlying grade 3 open injury right from the beginning, is this infected or not? So I did the joint aspiration, but the cell culture was negative, and also the microbiological results were negative after 14 days. The major problem often in the elbow is the soft tissue coverage. As you can see here, the soft tissues are close, but if you look at the elbow, you see how thin the skin and the soft tissues are, and this is not a good precondition for a big revision surgery that the patient needed due to the broken stem. So took him to surgery. I also discussed with him different options, but we opted, because we had ruled out at least to what we could do by joint aspiration. We had ruled out the infection, so we went for a one-stage. We took the broken implant out and we put in a new one, which did not have only one additional part for the extramedullary fixation, but had 2 parts, and also the central stem element was thicker and more stable. And this is then the surgery that was done from our colleagues from plastic surgery. As Lee had indicated, in such cases, you definitely need a multidisciplinary approach. And for that soft tissue conditions, I just didn't find comfortable to do that without a real stable and good soft tissue coverage. Therefore, this free latissimus dorsi flap was done. And here you can see the situation with the implantation of the new prosthesis. And here you see that the stem is thicker and was brought all the way down the ulna. And here also 2 extramedullary parts helped to fix the ulnar component. Soft tissue is healed. His free flap healed quite well. And the patient then was very happy, but 4 years later, he comes back with a chronic fistula, directly just close to the flap. And the X-ray looks like this. So at least to my perception, there were no signs of loosening. He got quite well along 4 years with that situation, but just between a few days that fistula developed, and then he came and asked for advice. So this is also then the picture you can see here. This big, it's not so aesthetic, but it helped to cover the entire elbow region, and therefore it helped quite good during those 4 years to salvage the elbow. Also here, joint puncture, it was a chronic situation, but with the fistula, we know that we do get a lot of, or it can be a polymicrobial situation. In that case, unfortunately, we did have a positive leukocyte count, but we didn't have any growth of any microorganism of it. The patient was still pretty healthy. Besides his polytrauma, he didn't have any relevant comorbidity, so he was a M0 or at least a M1 patient. So he was healthy and still willing to undergo revision. So once more, the X-ray, as you can see here. So what would you do now? What would you recommend? You have seen the patient with this chronic fistula. The region was already flapped by this free latissimus dorsi flap. You see this huge implant, particularly in the ulna, cemented, and also difficult to revise the distal femur component. The underlying disease is still a grade 3 open complex fracture a few years before, five and a half years before. So what would be your options? Suppression, one-stage exchange, two-stage exchange, try a DARE, amputation, or other options? So please vote. Not so many yet. Okay, other options. Two-stage, suppression. There is a race between two-stage and suppression.
Yeah, it's back. Yeah, the voting. I see that from 85 people, 30 already voted. Yeah.
Yes. Okay. So the voting is finished. The majority would go for a suppression antibiotic therapy. Some would try to do a two-stage. Third place, a DARE, amputation, only a very few, or other options. So I would show you what we did, or what I did. I did a DARE, and I exchanged the mobile parts, which is quite difficult for this discovery prosthesis, because I didn't believe that I could really successfully change the prosthesis in a 1 or 2 stage procedure. It's difficult to change the mobile parts here because the polyethylene in that elbow prosthesis is quite very well fixed, and so this was the most difficult part of the surgery, to get that changed. But the biggest problem was that the patient had a very highly resistant staph epi, as you can see here, and maybe we could discuss that later, Andre, but even our colleague from ID, from infectious diseases, did not have really good long-term suppression options. I think you might have them. And we will see that in this case, we did the vancomycin, followed by 6 weeks of vancomycin IV, followed by 6 weeks of fosfomycin. And I also did suppression here, in this case, with rifampicin. I mean, you might insult me now, but I did that, and at least 2 years after the DARE, the patient is happy, no further fistula, but I'm pretty certain he will come back one day. So megaprosthesis, not only of the lower, but also of the upper extremity, are challenging. Particularly the elbow is often associated with soft tissue problems. Interdisciplinary management always required, and salvage procedures are of importance. And thank you very much for listening.
Yeah, Volker, thank you for this special case. I would also probably do everything what is possible, and there is no algorithm for that. So I'm curious, maybe if Lee and Fabrice, you can join and see if you have any comments on this case? Would you do something different? Yeah, please.
Well,
I think Volker showed the importance of soft tissue cover, and in the elbow and the shoulder, I think it's even more probably important than it is in the hip, certainly. And we also showed the problem of multi-drug resistant organisms, which unfortunately becoming more and more common. And we published some data that showed that the outcomes in multi-drug resistant organisms are very difficult.
The patient had a fistula, and I believe that there will be a difficult microorganism detected, but that stuff epi was really very highly resistant, and it didn't give us many smart antibiotic options. And I did the free flap with the plastic surgeons, I think at a good time, because if we hadn't done that for the exchange of the prosthesis, we would have ended up with a soft tissue problem much earlier. But with a free latissimus flap, I mean, you can do a second one, but then it's getting really difficult.
I think we talked a lot about it last time, Volker. I know you have an interest in it in chemical debridements, and I think when we're dealing with these multi-drug resistant organisms, it's really important that we don't rely solely on the antibiotics. We have to remember that this is antibiotics help the situation, but really this is a surgical problem, and the only way you're going to really get rid of everything is a good debridement. But also, if you can have a solution that would help to break down the biofilm, then that is a really important part of the debridement process.
Yeah, it was a quite intensive debridement. I think it's one of the most intensive debridements I've ever done. I also changed the glass wires, and it was really very difficult in order and to remove that polyethylene in that elbow prosthesis. This was a nightmare, because you have a special instrument that then got stuck in the prosthesis, and it stuck out of the wound like this. It was a difficult intervention.
And in the first revision, Volker, how did you remove the implant in the ulna? How did you remove the cement? Did you ream? Because no,
I did not ream it.
So
I fenestrated the ulna. So I drilled in some holes in order to get one large piece, which was approximately 30% of the circumference, and then I took that off, and with the help of those two extramedullary parts of the ulnar component, I could then reinsert that bone piece into the ulna and cerclage it onto the implant.
Okay.
Because otherwise I would not have been able to remove it.
Well
and
done.
the very interesting thing about that was that the patient, he was an engineer, and he presented to me how the new implant should be designed, that it would not break it.
What you presented very nicely and mentioned is the solution to pollution is dilution of bacteria. We mentioned it in the previous one. And maybe I can just add from the antibiotic perspective that antibiotics only work if we can dilute the bacteria to a very low level. With a high concentration, no antibiotic will work, and this is called the inoculum effect. So, for example, an abscess, no antibiotic can cure, and especially in presence of an implant, if you do a thorough debridement and removal, then antibiotics can work.
Absolutely.
Excellent. Right. I think we have two more cases we can discuss after each one. Fabrice, now is your case, please.
Okay. So this is a 67-year-old patient. So he has diabetes, he's obese, his BMI is 46. and he had this prosthesis, and he fractured the stem of the prosthesis. So my friend in private practice did the prosthesis, but when it failed, he sent it to me. He's a good friend. And so I did the revision surgery using Genux prosthesis. So it's a hinge prosthesis with an EPO collar. And of course, it got infected. The germ was Staphylococcus aureus meties. So I did a DARE because it was an acute infection. The only trouble at this time is I didn't listen to the PGI seminars, and so I did my DARE at 2 months, and of course it didn't work. And so I had to come back in and remove the prosthesis, put the cement spacer, and you have these 3 germs. So we gave 6 weeks of antibiotics. And at that time, we did an antibiotic holiday that I wouldn't do now. And I proceed to the second stage. So we discussed whether to do a proximal EPR, proximal tibia, but the patient wanted something safer. So he agreed with an arthrodesis, so silver-coated arthrodesis cemented. I did well in the beginning, but used a short stem. I didn't use any screws. It was a cemented implant. I should have added 2 screws. And of course, his weight is 135 kilograms. So a little fall 2 months later, and he just smashed the proximal tibia. So he came back, of course. And so I revised him with a longer silver-coated knee arthrodesis, cemented with 2 screws. Patient happy, no pain, he could walk. So 5-6 years later, he comes back to the clinic. So there was a little bit of loosening of the implant, but it was not painful. And then there was the COVID, so I didn't see him for a year. And so he comes back in 2020, and then it's painful, it's definitely loose, and the tibial stem, CRP is 8 milligrams per liter. The distal stem, so it's loose on the tibia, but on the femoral side, it's perfectly well. You see a nice bone integration on the collar, which is a HA-coated collar. And so I did an aspiration, which was negative. But at the MDT, we discussed the case, and well, we thought, there was a good probability that this patient was infected. As you can see, the soft tissue is okay with local algerosis. So I took him back to theater. I did bone biopsy, staged biopsies, soft tissue biopsy, and everything was still negative. So I said, well, okay, so it must be a mechanical loosening, which was good because I didn't have to revise the proximal stem, the stem in the femur. And so we IMPLANT designed this prosthesis for distal fixation using an EPOR collar and a cortical plate for fixation with 2 screws. So this is how the implant looks like. So I did the surgery with this custom-made implant, so keeping the femoral stem. I did some new samples, sonication. We gave him post-operatively antibiotics, just in case. And of course, sonication, one sample came back positive with Staph hominis and Staph epidermidis. So we started this antibiotic regime. But at 3 weeks, the scar was not too good. There was a little bit of non-union, less than 1 centimeter. But so at 3 weeks, I went back in and did a DARE, new debridement. So I changed all the silver-coated parts. I took new samples, which were negative, but he was under antibiotics. So of course the wound didn't settle. There was a leak again, and I started with a chronic fistulization. So I did an aspiration, and this new aspiration found Staphylococcus hemolyticus, which is difficult to treat germ. So we spoke with the patient. You know that it can end up in amputation, but he's happy with the chronic fistulization. Can walk. He has no pain. Of course, I'm a bit worried with the follow-up. I saw him in the clinic 2 weeks ago, and this is the X-ray. So for the moment, it's good, looks good, but I'm a bit worried, and he's a bit worried. Thank you.
Thank you, Fabrice. It's a perfect title of your topic, Never Ever Give Up. And this shows, yeah, nicely that you should continue with the treatment before you do some radical surgeries. There is a question in the chat before maybe we discuss it. The question from Laura was, do you always use silver-coated implant, or which is your indications?
Well, in my practice, in infected revision surgery or tricky patient, this patient is obese, this patient is diabetic, so yes, I use first intention silver-coated implants. Bone tumor, I always use silver-coated implants. You know, they have chemotherapy, they can have radiotherapy, so they are patients at risk.
And Lee, what would you suggest?
Yeah, well, from my point of view, the evidence seems to be good that it works. So there's a number of studies now that show that it has prophylaxis benefits, but it also has some treatment benefits with silver as well. So we tend to use silver coated implants in all of our complex cases and all of our high-risk patients and all of our periprosthetic joint infections. But I think, as Volker spoke about probably in the first meeting that we had, you know, adjuvants are very important now. So, you know, especially with multi-drug resistant organisms. So, you know, silver will work on those. We'll use much higher doses of antibiotics locally with a stimulant or DAC or whatever. And really, as I said in my talk before, these are the last chances for a lot of these patients. So we'll throw everything at them, and it actually doesn't cost us much more to put silver on compared to non-silver. So it's a worthwhile thing for us.
And we can also say there is no resistance to silver. Yeah. You have a broad spectrum bacteria, also fungi. Yeah. So there is no risk of getting resistance. I guess, Volker, you would agree with these comments?
Yes, absolutely. And as Lee just said, I had that talk in the first seminar on the silver-coated prosthesis, and the more studies come up, the higher the evidence is getting. And I'm also using it in my practice for all complex cases, because as Lee said, we have to throw everything at the microorganisms that we can, and the local protection of the huge metallic surface. I think this is a quite important thing in the treatment of those complex cases, because the exposure of such a huge surface of metal that is unprotected is a very nice and attractive surface for bacteria, and therefore we have to protect that surface against the bacterial colonization and biofilm formation. And for the time being, silver seems to be the most effective agent to be able to do that.
Volker, last time you mentioned that you are sending prosthesis to put silver coating on it. Is that something you use often, and how do you deal with this?
Yeah, there are different points to balance. The silver coating, for example, from the Muta silver coating from ImplantCast. This is an officially approved product which everybody can use for each indication. It's completely and officially approved, but it does have the drawback that you can coat the silver only on the extramedullary parts of the prosthesis. You are not able to put it on the intramedullary parts. This has to do most likely with the relatively high amount of silver that is used with the Muta's technology, and therefore you cannot put it on the intramedullary implant, because this would, for example, prevent, or there is a likelihood that it would prevent the bony integration of the implant. And therefore, in some cases, when I need really a good intramedullary fixation, and I can do a cementless fixation, I do use a specific new silver coating technology, which is based on a nanoparticulate silver that is put on the entire prosthesis, on the intramedullary and the extramedullary parts. And this uses a much lower amount of total silver for such prosthesis, and therefore it allows also to put it on the intermedullary parts. But this has the big drawback that this is not officially approved. So you have to talk to the patient that you will use an implant for which the metal implant is approved, but in addition with the coating, you will use officially non-approved implant and prosthesis in that case. And at least in Germany, you can do that in desperate cases in order to avoid amputation. But this is a very small window, and I have to discuss that, and I have to obtain informed consent from the patient for each and every case when I do that.
So it's an off-label then situation, and
yes.
You can say the patient, don't worry, everything what we are doing with you is off-label, including antibiotics. So we are trying to do the rational, the best.
Yeah, but I'm still, we are used, and we have been trained to use only officially approved metallic implants. So therefore, this is for us. I mean, you as an ID physician, you are using antibiotic doses as high as you want. That's your problem. But we have to introduce and implants, and they should officially be approved.
Yeah, it's
but
a good.
In desperate cases, in desperate cases, I've made very nice experience with that. I had presented this total femur case during the first session, and this technology seems to be also very helpful. And I do believe that the underlying antimicrobial agent, which is the silver, is really of big help in those complex cases.
I think you may be covered also by the Declaration of Helsinki, saying if there is no standard option available, you are allowed to use also off-label products. But you mentioned a good point that the patient should be informed and consent before this use. I know, Fabrice, do you have any also experience of off-label situations or silver coating?
No, I haven't used this nano particle technology. Have you, Lee?
No, I think it's important to know that there are several companies that do silver coating prosthesis, and they're all slightly different. So Link does a silver coated implant, and Stanmore, now owned by Stryker, but the dose and the duration of the amount of silver that is eluted is very important. So on the implant system, for example, the silver stays around for a very long time, and there's some evidence that you need a drop in pH to allow an increase in elution of the silver, whereas the passively eluting silvers tend to go very quickly. They're probably gone within a week or certainly within a month. We did some drain studies on the Stanmore implants. We found that the amount of silver that was eluted was very high initially, but then fell off very quickly. So that's a prosthesis that you may want to consider for prophylaxis. whereas the amount of silver perhaps is important. So different horses for different courses.
Very good. There was a comment, is there a good option for chronic infections? And maybe I can also comment on that, that of course this is not according to the algorithm if you want to aim the eradication. But in such situation, when eradication anyway is not possible, I think that's a good option for reduction of the bacterial load, and then we go for suppression. And this surprisingly well is working much better than removing all the prosthesis. Do you have any thoughts on that, maybe Lee?
I think we have to be very clear about what our treatment goal is. You know, very few people die with infection from a joint replacement. There's in my practice because of periprosthetic joint infection. Most of these organisms are relatively low virulence, and most of the patients can cope with having an infection. So sometimes having a patient that you're not trying to cure their infection, but you're trying to maintain their limb and give them quality of life is just as important. And I think we have to be practical. In a case like a total femoral replacement, very often we're not going for cure, but we will do a dare and change everything that we can do to get the most up-to-date organism, and then to allow, hopefully, decreasing in their bacterial load, but also to allow the right antibiotics for their suppression.
And maybe also at this time you can introduce some local antibiotic carriers.
Absolutely.
And that was another question. I don't know, Fabrice, would you like to comment on that? If you use some calcium composites loaded with antibiotics, Stimulan or Cerament or other products, Curasan is another one.
Yes, I use the DAC. And so I got the prosthesis with DAC. It's a little something more for the first 3, 4, 5 days per. And so yes, I use this for yes. We have used Cerament too in second stage. So I agree. You take a little bit of everything. You know, if the silver can help, you take it. Cerament can help, you take it. That can help, you take it. I think
I think the one thing that we've changed in our practice is that if we've had a patient that's had a wound that's been open for a long time, then we'll prophylactically put antifungals in, because we're seeing patients coming with a lot of fungal infections now. And I think that's the beauty of adjuvant like DAC or Stimulan, which we tend to use, that it allows you to put in other antibiotics, but you're not hopefully causing antibiotic resistance to the patients. You know, you're just giving a local high dose. And for me, we'll often put in amphotericin, lyophilized amphotericin, or voriconazole when we know that a patient has had a big wound that's been open for 2, 3, 4, 5 weeks, because in a poor host, they're often colonized by Candida.
For fungi, indeed, we have no biofilm active antibiotics or antifungals, so we need to combine it, systemic suppression and local, hopefully high concentration to, if possible, eradication. Volker, there was a question about the gap between the 2 stages. What is the parameter you choose to say, now I will reimplant?
Yeah, we tend to shorten the interval. When we do a 2-stage, we tend to do what we call the short track procedure. So we leave the interim period as short as we can, up to only 2 weeks. Let me say, it's, if you have a patient who has soft tissue conditions and not so good for 2 big surgeries within 2 weeks, we try to extend the interim interval. But as Fabrice and Lee have said before, I mean, you always need to consider that the patients do not very well in this interim interval. And I always compare it with femoral neck fracture patients. We have, at least in our country, but I think in your countries too, we have the law that we have to operate on a femoral neck fracture patient within 24 hours. And if we leave a girdle stone situation in a patient who is at least as sick as a femoral neck fracture patient, and we keep him bedridden for like 2 months before we do the next procedure, so there's a huge gap. So therefore, we try to shorten the interval, but we also know that the wounds have to really heal adequately, because if you have a wound that has not healed well, if you still have bad soft tissue conditions, your reimplantation will fail. On the other side, if the patient is really very, very sick, if the situation is very complex, and Leah and Fabrice have shown those cases, we try to do a one-stage, even if normally a two-stage procedure is indicated. But I think, Leah, you had that term also on your slides. We have only a one-shot surgery. So you have just one try, because it's only one procedure you can do. Even if you do the flap surgery within the same procedure, then we go for a one stage. Even in a normal setting, we would go for a two-stage, because we know that life expectancy is limited, and we hope that the infection will only come back once the patient is already dead.
So to ask Andre a very quick question, there's some evidence that prolonged antibiotics after 2 stages have better outcomes than one stopping your antibiotics at the 2nd stage. When we do these very sick patients and we're doing them as a 1 stage, how long would you normally recommend antibiotics continue for? 3 months, 6 months, 12 months, or lifelong?
That's a good question, because before we said if all cultures are negative at the time of reimplantation, you could stop the antibiotics. And that was probably a mistake, because we have no real tests to show or to prove that we are infection-free. So I would always, if the aim is eradication, start with biofilm active antibiotics after reimplantation, no matter how long was the gap and how much antibiotics were given before. And if there's some problematic, difficult to treat pathogens, you mentioned Lee before Candida, for example, then we would go after the eradication and continue with the suppression, because the worst case would be a relapse. You have no much possibilities. So there's nothing wrong to give suppression.
Perfect.
That is perfect. Now introduction, Lee, to your case, salvage approach.
Okay, so I'm just going to show you a quick case to show you how patients can do. So this was a 54-year-old gentleman who was a managing director of a company, very wealthy. He was enjoyed paragliding, and he had bilateral tibial fractures. One was treated with a frame, and one had an attempt at fixation. This was the attempt at fixation, and then he was treated when it got infected by a non-specialist who did a homeopathic spacer. There's a very, very poor spacer here that the patient is unlikely to be able to walk on, or is unlikely to give stability to eradicate the infection. So then the patient underwent a proximal tibial replacement, again at another unit, and you can see again there's a lot of shortening, the fibula's impinging, and it remained infected. So the patient here has had a proximal tibial replacement, continues with a chronic infection and a small fistula. He travels from the UK to Munster to undergo radical treatment. He had a 1-stage combined distal femoral and proximal tibial replacement with silver. He had medial and lateral gastrocnemius flaps. You can see they've had some excitement in getting the stems out at the time of surgery. But unfortunately, he continues with a chronic infection, no active extension, he's got E. coli, so not a very nice organism. He was told that he needed an amputation by several units. He self-referred to me, but he'd also taken opinions in Vienna and the USA. So you can tell this is a very high demand patient. We took a first stage revision with a free latissimus dorsi flap. We used a spacer with 6 grams of vancomycin and 3 grams of meropenem. You can see it's the usual sort of Lee J's minimally invasive small blood loss surgery. We managed to remove the implants, and we ended up with a long spacer. But this is the effect of his free flap. This was at about 3 weeks following, sorry, a bit longer than that, about 6 weeks following surgery. And you can see then that the most important thing is to get the coverage. Here we've got a silver-coated arthrodesis, and I think one of the things that if you are going to use this, then you want to use the RS stems, and there is a coupling device if you can. So standard, they'll give you a 125 millimeter stem on the tibia, and as you saw from Fabrice's talk, then that can run into problems. All of these arthrodesis prostheses are going to come loose at some point because there's no resistance to the rotational forces, but you want to try and give it as long as possible. So this is the patient here, and you can see that the implant has got a slight flexion built into the implant, and it's got a slight valgus built into the implant as well. And this is the patient. You can see walking. The function of arthrodesis is actually surprisingly good. Disappointingly, their Oxford knee scores are only slightly below that of revision knee replacement. So for us, it's a good option. One of the things that the patients really dislike with a knee arthrodesis is the difficulty in driving. We've managed to find some local car fabricators that will make some special car seats for the patients so that they can get their, with a trough in, so they can get their leg under the steering wheel to carry on driving. We published our initial series of arthrodesis some time ago now. So we had 8 patients, mean follow-up of 16 months. We hadn't had any amputations, deaths, or implant revisions at that time. We had 1 case of recurrent infection, which we managed to treat with a DARE because it was a silver-coated implant, and their Oxford knee scores significantly improved. So this is Fabrice's case that I've pinched on, as he showed me before, but also you can see one of my cases where the patient has drifted out, and the question is where do you go from here? So this is another case that had failed after about 7 years. It is possible to revise them. We did a extensive debridement, and here we've had an implant that has gone through the ankle joint to combine it into an ankle arthrodesis, an uncemented implant through to the ankle with impaction bone grafting, and 3 years later the patient is still doing okay. So you can revise these implants, but again, I'd recommend longer stems, and impaction bone grafting seems to work quite well in these cases. Thank you.
Thank you, Lee. That was indeed an excellent case for the end of our webinar. I would like to thank all the speakers. I hope we can still get all shortly in, and to say first thank you from my side for your input and experience. Thank you also to all the attendees. We had more than 80 attendees all the time and for all the questions. So at this point, I would say goodbye to everybody.
Bye-bye. Thank you very much.
Thank you. And we will show some wrap-up slides. First, that we will have next time our online seminar on megaprosthesis on the 28th of September. This webinar will be a special one because we will discuss your cases. You will receive more information in the email tomorrow. How to send your cases with megaprosthesis and infection by 15th of September, so we can discuss and prepare our best recommendations next time. So the speakers today dealt with many topics. One was the theoretical and antibiotic backgrounds of the algorithms. Then we heard from Volker Alt the TNM classification and implication for the treatment, followed by individual patient-adaptive solutions from Fabrice Fiorenza. And finally, we saw salvage procedures from Lee Jace. The next online seminar of 6 modules on periprosthetic joint infection will start in September, so after the summer. And here we will go into more details related to PJI, and afterwards in November also on fracture-related infections. We all hope that we can make also seminars again in presence soon. And with this, I thank the people behind the scenes for the organizational and technical support, and of course to you. And I should not forget also that this seminar, this webinar, was done in cooperation together with Hereus and ImplantCast, who supported this event. Thank you, everybody, and goodbye.
Bye-bye.
Bye.
Bye-bye.